And also there is a discussion, but certainly I would say diffuse osteoporosis and other secondary events like hyperparathyroidism and also the single asymptomatic bone lesion that cannot be confounded with multiple myeloma. So we have to be and differentiate those conditions. What should we do? And basically here is the list of tests we should perform for the smoldering myeloma, medical history, the hematological test, basically the creatinine and calcium, and then the usual protein studies, the M protein, the urine, the immunofixation, the free light chain. And here we are then moving to something, bone marrow biopsy, yes, if we have already more than 3 grams, otherwise I would be probably more conservative. Certainly the skeletal survey today, probably this should be changed with a low-dose CT scan that is much more sensitive, less radiation for patient, and definitely much more precise than the skeleton. So today, from this point of view, before moving to other conditions, certainly I would say the low-dose CT scan might be considered. And finally, the MRI to have the final definition of the very small lesions. Another issue is the moment you see if we have a stabilization of the M component. We did the workout, and there is an M component that is stable, probably I would say between 3, 4. Check every single year is probably needed to see that nothing is changing, although we will see the risk of change is getting lower with time, but is still there, and we cannot rule it out after, let's say, 1 year or 2 years of follow-up. This is the problem, and the problem of the evolution that more or less is the same story of myeloma, because we have a proportion of patients, around 50%, with a propension to evolution that is very high. It's 10% per year. So you have among all these patients, 3 grams, 10%. You have 50% that, almost 50% of patients who will have a 10% risk of evolution every single year. And then you see as is plateauing the curve of myeloma is more or less the same story here. You see the one with a very good genomic stability. So these are the ones that will not change later on. And you can see from 5 to 10 years, you have only 3% risk of evolution per year. And then you basically go down to 1%. Basically, you are going down to MGUS. What is the change here? You have probably, from a mutational point of view, you have a tumor that has a high propensity to change on time and is evolving to myeloma, and the other one that is a pure MGUS. But unfortunately, the problem we have that is today, our ability to define those two categories is not as good as we might want to have it. Another issue that is important from a clinical point of view, this is what just I was saying before, there are several ideas, but still we do not have the biomarker to test it. Certainly is a matter of clonal evolution. Certainly some patient has, some tumor has a risk of clonal evolution that is very high, someone else do not, and this makes the difference from the clinical behavior we were seeing before. So how can we define it today? And certainly the definition today is, as we were saying before, 3 grams and 10% of plasma cells, and you can add to this the aberrant plasma cell by immunophenotype, reduction of uninvolved immunoglobulins, evolving free light chain and abnormal ratio, as well as the bone marrow infiltration that is already a definition of myeloma. A concept that has not been used too much and probably should be improved in the future is the evolving and component during time, and certainly imaging. Imaging is probably what is changing today the definition of smoldering myeloma, and you will see why. First issue, this is certainly, a lot of this work is, have to acknowledge, is coming from the Spanish group, and you can see here the presence of basically two parameters. Of course, more abnormal parameters you have, higher is the risk. So you have here abnormal plasma cells in the bone marrow, plus or minus immunoparesis. So you can see that if you have no parameter, everything is very good. The moment you have only one parameter, you start to have a higher risk of a transformation, and the moment you have two parameters, you have certainly a much higher risk of transformation. But once again, here you are talking about 82% of patients basically at 50, 60 months, 5 years. So once again, this is the crucial issue for the smoldering. You know, how can you possibly treat someone who might be asymptomatic for 5 years, but certainly here you have 80% probability, but you don't know which one is really going in the category of the transforming patient. The evolution pattern is similar. We have here a risk of transformation that is 50% at 2 years. And I have to tell you, my personal opinion is that we should have, but it's not easy, to have a biomarker that is telling us that someone has, within 1 year, 80% probability of transformation. This is where I wouldn't have any type of doubt on starting treatment. I have more doubt on starting treatment when you start to have, once again, 50% at 2 years. That means that probably is 80% at 5 years, but still you have a high proportion of patients who might not need any treatment for a longer period of time. Anyway, going to this risk, the evolution pattern of M-spike, here is a 25% of patients might have an increase of 10% in the first 6 months. Now the definition is increase in 25% of M component in 6 months. So a sort of progression of the M-gas status in 6 months. That's probably today the best possible definition we have. And certainly, on the other hand, there is the 75% on patients that are, on the other hand, not evolving. Other story, this is the story, of course, that a high risk or standard risk patient, if you start to have 1Q, 29% incidence, this is probably not so relevant. The most important still are these three, deletion 17, 4, 14, and I would probably add 14, 16. So the presence of chromosomal abnormalities is, of course, telling us that is a higher risk of transformation. So this is, once again, one of the parameters who might give us a sort of tool to define where we have probably to start early on a treatment. Here you can see the difference of the different abnormalities, and you can see here 1Q, 3-7 versus 5 years, deletion 17, that is always the worst, 2.7, 4.9, and once again 4.14 versus 4.14 to 2.9 versus 5 years. This is something that probably will come more useful in the future if we have an evolution of this technique, and with all the new genetic tools might represent something that might help us probably more in the future. And you can see here is the gene expression profile of those patients, and once again you can have here the 85% risk of progression at 2 years. So this is something that becomes, to some extent close to what I personally believe is the golden standard, and should be 80% probability at 1 year. And this is probably something that could, in the future, if confirmed on a larger series with all the limitation, might represent something that might represent an important tool for the definition of the very high-risk smoldering myeloma. Now we move, and this has been the concept that the IMWG followed to transform a definition that is always a definition that is not clean, with a lot of limitations. And I have to tell you a story that I personally have with a patient. Actually, he was a relatively relevant pharma person. He was plenty of small focal lesion at MRI, but he was in an excellent clinical condition. And he said, well, I was totally in favor of starting because many focal. And he said, well, listen, I'm fine, I'll wait. He had been waiting 10 years with focal lesions. So you see, the definition of, once again, the problem is the biology that is behind the disease. And we cannot test it today. We do not know if we have a biology that will transform in a growing tumor, or we still have a tumor that is not with a major growing potential. This is the major issue, biological issue we have. And with all this type of definition, we are trying, but still, even the small focal lesion might have some patient that will be stable for a year. So having said that, these are the definition. And today, once again, you can see here 60% probability of transformation at 20 months, free light chain more than 100, no CRAB. This is the definition of myeloma today. So this is the start of treatment that has been currently defined. And the other one is bone marrow plasma cells more than 60%. So once again, these are the two major, with imaging that I will touch in a second, these are the two major change in the definition of myeloma. That means start of therapy. So without CRAB, everything is negative, imaging is negative, 60% plasma cells, free light chain ratio more than 100 is today the definition of start of therapy. Now, moving to imaging, it's a complex situation. I'll give you my I don't have, to some extent, too much evidence on this. My major message is, please leave, if feasible, the current skeleton survey on a side and move to low-dose CT scan. To some extent, today is the best simple way, and certainly with low-dose CT scan, you start to see lesions that you were not seeing before. So that, I would say, is the major change we have to adopt in our clinic. Having said that, then we have a second level of imaging that certainly is MRI and is CPET scan with limitation, because CPET, the specificity is 50%, MRI is not so relevant in the definition of some lesions. So here we start to have some limitation, but certainly they are more sensitive than the previous test. And you can see here how without this imaging, at the end of the day, we are lacking a myeloma diagnosis, because if you see here, you can see here that at least 30% of patients have focal lesions, so probably something you don't see with X-ray, and 50% of patients have diffuse infiltration. So the major message that was coming beside the free light chain and plasma cell infiltration is to use a more advanced imaging techniques, because this is certainly increased the number of patients with already present organ damage as bone lesions. So from this point of view, certainly, as I was saying, at least what we do, low-dose CT scan is the change, and then certainly the MRI or the CPET might represent a further tool for the test. You can see here, but once again, we are more or less in the same story. Here is time to progression of 13 months with more than one focal lesion, and here time to progression was not reached, but still you see in the both situations you still have patient that might not evolve and someone that is anyway evolving despite the negative MRI. So to close my presentation, basically I would say two concepts. The concept is number one, this is coming from W, more than one focal lesion on MRI studies. Today this is considered internationally the change in the status, and this is the definition of myeloma. 60% plasma cells and free light chain more than 100. This is the new definition of myeloma in absence of any other evidence of organ damage or CRABs. Now the issue is the following, and I believe that Marie-V will tell us much more from a treatment point of view. Should we treat this patient or not? And certainly there is a plus or minus. I'm personally very neutral on this issue because I'm, as you know, very in favor, and I think that was the major finding coming from the Spanish group. If you treat early, you get the best possible results. But on the other hand, as I was saying, the risk is that you might treat someone that for 5 years is not probably going to have a major need of treatment. So which are now the definition of high risk? IgA, so non-IgG component. As we were saying before, immunoparesis with reduction into uninvolved immunoglobulin. Serum involved, and this is probably becoming more and more one of the major ones, because you have a number, so you can say yes or no from this point of view. Serum uninvolved free light chain ratio more than 8, but of course less than 100. So this is probably one of the major definitions of high risk. It's probably not because it's better than others, it's probably simple, more simple than others. And then progression increase in M protein level, 25% on 2 different evaluations within a 6 months period. So I would say, and personally, I would say that these are probably the more simple, IgA, immunoparesis, free light chain 8, 25% on 2 different evaluations within 6 months. This is probably something to keep in mind to the evaluation of the high risk. Certainly, if you have the technology, the presence of abnormal plasma cells, the bone marrow, and the presence of the major 414 and deletion 17 alteration, circulating plasma cell becomes something more complicated, probably not so evident. And today, we are looking at this, and the MRI with diffuser normality or only one focal lesion. And this one, again, is something with some caution from my point of view, but certainly CPET with local lesion and increase update. So you see, you have once again, you have 3 different issues here: the protein, the bone marrow, and the phenotype and the imaging. To close, and this is my conclusion, I said it already, so I would like to, and we have to work to find something that gives us 80% probability of organ damage. 1 year will be excellent, 2 years might represent, but certainly I want to see someone that has a very high risk of transformation in at least 1 to 2 years. Of course, from this point of view, we need a better definition of high risk smoldering, and maybe we need also at least on some test, free light chain 100 bone marrow, confirmation by other series of current definition of or early myeloma that needs start of therapy. That was the last one. Thank you very much.